तो इंडिया में अभी बात को कंसिडर नाते हुए मतलब का बहुत वो लोग की पार्टी को विपक्षी पंचायत के पार्टी से भी करते हैं करने के बाद क्योंकि तो मन से हम किसी पार्टी को बहुमत नहीं मिलती
Zaid sir, good evening.
पार्टी का रोल रहा है उनका सरकार बनाने के लिए
Yeah, good evening, good evening.
Sir, good evening. Good to see you, sir.
It looks like sitting on some.
6 o'clock will be live, sir.
Yeah, no issue. I'm there.
Yes, sir.
Everyone can put the SNCC background if possible. It looks good.
You can download it from.
Ask Dhawan to forward it to everyone. Na? It's just 2 minutes job. Prashant. Prashant has to do that.
Yeah, yeah. Yeah, we are live. Okay. Good evening, everyone. I am Dr. Yash Javeri, Secretary SNCC. On behalf of Society of Neurocritical Care, I take privilege in inviting you all to this head injury awareness symposium. Today is Head Injury Awareness Day, you all are aware. And to mark this day, we have a series of sessions. We have two small talks followed by a panel discussion. I like to invite Dr. Prashant Kumar for the vote of introduction. Over to you, sir. Dr. Prashant Kumar is President SNCC and is a Professor of Anesthesia Critical Care at PJIMS Rota. Over to you, sir.
Thank you so much, Yash, and thanks everyone for joining us. All the speakers for the day, all the chairpersons, all the members of society and other societies. So it's a very good feeling to have all of you joining us on a very important topic, which is a very common thing in our Indian context, especially. When we talk about head injury, it is not only the road traffic accidents with the two-wheelers, but it is equally affecting the four-wheelers and falls to the elderly and children especially. Also, there are sports injuries which come up sporadically, and this definitely makes up a very important thing which our society works towards decreasing the incidence, looking at the prevention and management strategy also. So thank you, Yash, for taking the pains and organizing this day for the society. And I'll request you to take forward the proceedings for the day.
Thank you, sir. I'd like to invite our chairpersons for the day, Dr. Kapil Zirpe, sir. Dr. Kapil Zirpe, sir, has been the past president of SNCC. He is a very senior intensivist from Pune. And we all know his keen interest is neurocritical care and stroke, brain death declaration. And we also have Dr. Ranveer Tyagi. He is on his way. Dr. Ranveer Tyagi is the sitting president of ISCCM. He is from Agra. Over to you, sir. Dr. Tyagi, good evening.
Good evening, Pranam, Radhe Radhe.
Radhe,
Thank
Radhe.
you very much for inviting this prestigious program, Head Injury Awareness. This is a very important issue, especially in the developing country like in India, where lot of death due to just because of the head injury. Majority of patients die in the trauma is the head injury. So how we can create awareness and how can we prevent, this is very important. Not only the critical society will treat the patient, how we prevent the type of incident, we can work on that. That is my basic purpose, or this is the aim of our society. Along with the SNCC, we work together to take this and help to people or society of our country. Thank you.
Yes, good evening and good evening to everyone, and welcome you for World Head Injury Awareness Day. We need to know that this day we need to follow the 365 days because it is not only the prevention of the head injury, it's a management of head injury. And if you see round about, there are 4 to 5 million accidents happens per year in India. Out of that, almost 1.5 million approximately met with the leads to the mortality. But if you see the theme of the this year's World Head Injury Awareness, there's a road to rediscovery. It is related with us. It is related with the neurointensivists. It is related with the intensivists, trauma surgeons, neurosurgeons, everyone. Because see, road to rediscovery is need to understand that it is not only mortality which is the worst with the trauma victim. It is their morbidity. They spend weeks to months in the critical care areas, trauma unit, then go to the step down, then go to the home, and their recovery takes again few months to years. So throughout all this period, they go through the miserable pain and the agony, physical, mental, and the financial stress. Entire family, in fact, goes through the this type of the situation, and we need to understand that our job doesn't end by admitting and saving the lives. Our job ends when these particular victims, most of the time they are youngsters, youth, going back to their what that or their near normal situation. So road to rediscovery is a theme for this year. So we need to understand the morbidity part of the trauma. So it's a huge spectrum from the prevention by the road safety till they regain their near normal lifestyle. And whatever that happens in between, we need to improve in that to reduce their this journey. This journey is a physical, mental, and financial journey of the trauma victim. So with this background, I hand over to the Yash for the proceedings. We have the program lineup. Yash, you will introduce the next speaker and
Yes,
we
sir, I
can
will do
start the
that.
sessions.
Thank you,
Yeah,
sir.
thank you.
Thank you for the words of introduction. The next speaker is Dr. Shruti Sharma. Dr. Shruti Sharma is working at DMC Ludhiana. She will be talking about preventive aspects of brain injury. Over to you, Dr. Shruti Sharma.
Good evening, everyone. Thank you, SNCC leadership, for giving me this opportunity and giving me the opportunity to speak on this very pertinent topic. I'll now share my presentation. Sorry for the glitch. So the topic for presentation today that was given to me was head injury awareness and from road safety to community awareness. So as we all know that we are passing through a silent epidemic. Head injuries and road traffic accidents have increased, especially in Indian subcontinent. It has increased to extent is too much. The global toll is about 1.1 millions of deaths annually and 20 to 50 million of non-fatal injuries. But it's surprising to know that 9 out of 10 fatalities occur in the lower and middle income countries, despite them being having only 60% of the world's vehicle. And in India, it is disproportionate burden is there. India ranks 1 in the global deaths due to road traffic accidents. And 4.73 lakh road accidents occurred in 2024, and 1.7 lakh to 2.7 lakh deaths occurred due to 2024 due to road traffic accidents. And this amounts to 10 to 13% of the all global road crash fatalities. So the burden in India is huge, and we top in the world in this. And this is not a very good thing to happen. Initially, it was 1 death every 5 minutes on Indian roads, but currently it is projected that 1 death occurs every 3 minutes. Now that amounts to about, you can say, a Boeing is crashing every day. That is the amount of the burden that India is scaling. So which is the vulnerable population? The population, young adults, 5 to 29 years. Road traffic accident is the most common cause of death. And 2/3 of fatalities occur in the breadwinner of the family, 18 to 59 years. Those come to these accidents. And most oftenly pedestrians, two-wheeler riders, bike riders, this is the majority which suffers these injuries. And because the two-wheeler boom is there, and in India, two-wheelers is the two-wheeler epicenter. So these are the victims which suffer most of the accidents. Either there is disability or there is death. So 2030 agenda for the WHO for the sustainable development is the ambitious goal of reducing the road traffic deaths and injuries by 50% by 2030. So what are the most common causes? The most common cause is overspeeding. You can see that 7 out of 10 fatalities occur due to overspeeding. And then comes the unprotected head, that is the not wearing the headgear properly or not wearing the headgear of good quality. The guidelines say that the helmet borne should be of good standard, ISI marked and Bureau of Indian Standards certified. So and snugly fit and right size, right age. So sometimes this is not worn at all or it not properly set in on the head. So that also amount to injuries. Then restraint in the ignored seat belts. Though we in the front passenger seat and driver seat we do wear seat belt, but hardly anyone wears the seat belt in the rear when in the rear passenger seat. So that are some of the causes of the fatalities. Then impairment and distraction. This has become a very common problem that under the effect of alcohol or other drugs or due to sleep deprivation, the drivers suffer an accident or a mobile usage, texting while driving. This and sometimes you must have seen that bike riders are using the mobile, listening to mobile and driving. So that also adds to the hazard. Suddenly some cattle or some animal comes on the road and they suffer injuries. So other causes are poor road engineering, poor lighting. These all amount to cause the road traffic accidents or head injury. So this all has to be protected. And among all the causes which I've already said, the underage driving, this is now a recent menace because school children, early college age children who are not of the approved age, they are driving the bikes, two-wheeler riding, pillion riding, triple riding is happening. You must have heard about the case where a young boy lost his life when a minor was given an SUV and he caused this accident. The boy lost his life. This was highly publicized. So the laws are not stringent and the parents and teachers guidance and everyone should guide their children to follow these laws. So how to prevent this head injury incidents in India? Awareness is needed and we should follow the rules and regulations. The change has to come from within. There is actually lack of awareness in semi-urban and rural population. Apathy is there, social media boom is there, so everybody is making reels. There is lack of fear of the law and lack of role models also. Even in movies you can see without the movies show the people not wearing helmets and doing the bike stunts and all. So what are the law and regulations? The laws are stringent, they are there, but basically the problem is that we have to follow them. The helmet laws in India is already stated. We have to follow the standard for the proper standard for the helmet, and it has to be worn above the 4 years of age, even for the pillion rider. Seat belt rules are also very clear that driver as well as the fellow passenger has to wear the seat belts while driving. Drunk and driving laws are that any alcohol permissible is less than 30 milligram per 100 ml, and any amount more than that slows the reaction time, impairs the judgment. So the traffic police does have breath analyzer test, and they are testing at many chonks and crossings. But we have to follow the rules from our own side. It is not that they cannot test everybody and anybody. So whenever had alcohol or something, we should not drive, and we should ask the other person to drive, or we can take a cab or public transport. So these are some of the laws and acts that have been, and fines and penalties that I have compiled from the regulations. That mandatory helmet use should be there, and no seat belt is also has a penalty, and overspeeding, dangerous driving, drunk addictive substance driving, using mobile phone. These all are punishable, and death caused by drunk driving amounts to culpable homicide without intent, and it is section 304. This can amount to 10 years of imprisonment or life imprisonment depending on case to case basis. So how to prevent head injuries or how to prevent road traffic accident? At the global level, many national bodies are helping us. That United Nations, WHO, they have made a Helmet for Hope Foundation. They are educating the people and distributing helmets to 1,000 cities in 80 countries. Then at the national level, we have Ministry of Road Transport and Highways, which celebrates these weeks. January 11 to 17 is National Road Safety Week. Today is Head Injury Prevention Day. Then Sadak Suraksha, Jeevan Raksha media campaign. This is highly publicized campaign where they educate the people, hold seminars. Then Department of Consumer Affairs, Bureau of Indian Standards. These all bodies work for the people, and so that the stringent measures can be taken whenever the law is broken. Various NGOs have come into front. For example, Indian Road Safety Campaign. This is important because this started in 2014 after college students, 4 students died in a college crash. So their friends, IIT students started this NGO, and now it has a lot of partnerships going on. Then there is Indian Head Injury Foundation, Save Life, Arrive Safe. State police also drives. They hold rallies, they hold social media campaigns, and they have distributed free helmets. So everybody has to work in collaboration so that we can prevent the road traffic. These are all preventable deaths. If we follow these stringent measures, these deaths can be prevented. And we can educate the people, hold rallies, take pledges, and young children should be taught so that they shouldn't be driving two-wheelers without any license, without any guidance. And so these should be done. Road traffic sign, this education should be there to all the people around us. So what are the challenges unique to India? The problem with India is India has two-wheeler dominance. So two-wheelers without the protection of helmet is a very scary and very accident-prone thing. Then other is rural and semi-urban areas, still the awareness and education is less. They don't feel that the helmet is necessary. So their education has to be there. Then the quality deficit. Many people wear helmet, but those are not good quality. So we have to ask them to use ISI certified helmets. Then sort of cultural resistance is there. Some cultures, they don't feel the necessity to wear a helmet. And in females also, we have seen that many of the females wear chunnis around their head to prevent from dust and pollution, but they hardly wear a helmet. So we have to bring this cultural change also. And we can see festival spikes near Diwali, Holi, New Year. Drunk driving is there. People go to rave parties and go back home in an inebriated state driving vehicles. So that increases the accident rate and victims coming to emergency in these special times. So a police drive is there and they try to prevent these injuries. So how do we smash the barriers? The new regulation is that every two-wheeler, they must be supplied with helmets also, 2 helmets. So this has started from January 1, 2026, that BIS certified helmets will be given to those who will be purchasing two-wheelers. Enforcement with the help of CCTV has increased. They have the traffic police does the black spot identification and they mark that area as an accident-prone area. So that surveillance has increased. CCTV surveillance and e-challans are issued to people who are overspeeding. So that has also increased the surveillance. Stricter laws, higher penalties, but relentless advocacy has to be there to prevent this menace. And this pyramid, we have to reach to the top of this pyramid, then we should have robust infrastructure, good investment from the government side, robust legislation should be there, rules and regulations are already there, we have to follow them, and strict enforcement should be there. And behavioral and cultural change is a must. Community education, youth advocacy, and social norms should be broken, and zero tolerance for drunk driving, and I would also say underage driving, because these are very young deaths. We have to prevent them. So underage driving and drunk driving should be a strict no-no. So how do we do this? We have to change ourselves first, then we can ask others to change. So this creates a ripple effect, impact beyond the individual. So be a role model, as action works better than words. So let us pledge that we will always, whenever we see somebody driving a two-wheeler or we are ourselves using a two-wheeler, we will always wear a good quality helmet. And whenever we are in the front seat or a rear seat of a car, we will always wear a seat belt. So change will begin from within us. And with that pledging, I'll close my talk here, and it's open to discussion. Thank you and be safe.
Thank you, Dr. Shruti. Thank you for enlightening us on the very important aspect. We understand a large amount of severe traumatic brain injuries can be prevented. Helmet alone can prevent up to 74% of serious traumatic brain injury. Seatbelt can avoid 50% of road vehicle accident-related deaths. So it's a huge burden, which is preventable. We'll take the questions at the end of the presentations. Dr. Nirpesa, shall we proceed?
Please proceed. Before that, just one very important thing to add. Dr. Shruti, excellent summarization of the very big topic. But we always should have a lot of workshop on how to remove the helmet. That is one of the major concern in
It
RTS.
should be
Yes.
snugly fit, and there shouldn't be gap between the chin, and it is a
No,
proper
how
way
to
to wear
remove after the accident, how to remove the helmet
after
is
the
not
accident.
stopped.
Okay,
Yeah,
sir.
that's very
Okay, sir.
important part of the this preventive aspect. But I agree with you, whatever you said. Thank you.
Thank you, sir. Thank you very much.
Thank you. Thank you, Dr. Shruti. Thank you, sir. We move on to the next presentation. Dr. Bhakti Prasad is joining us from Odisha, and he will be talking about acute care of head injury
Good evening,
patient, the pre-hospital care, and the emergency care. Over to you, Dr. Bhakti Prasad. Thank you.
Good evening, sir. Good evening, sir. Is it visible?
It's coming up. Yeah, it's there now. Yes, Dr. Bhakti Prasad, you can start.
Good evening, esteemed colleagues, seniors, and friends. Today, I am going to present this early recognition and initial management of head injury. So, coming to early signs of head injury, these are changes in mood to severe physical symptoms like loss of consciousness. These signs often appear immediately after a head injury, but some may develop gradually over hours, days, even weeks. So, traumatic brain injury. This thing may there may brain damage, skull fracture, fainting, temporary amnesia, irritability, head injury, speech violation. So patient may be having a loss of consciousness, vomiting. What are the early signs that are seen in the case of a head injury? So these are maybe categorized the physical signs that are persistent and worsening headaches, nausea, vomiting, dizziness, loss of balance, and sudden fatigue or drowsiness. Then come to cognitive changes. They're feeling dazed, confused, foggy, short-term memory loss, sensory issues, blurred vision, tinnitus, sensitivity to light, changes in ability to taste, smell, emotional and behavioral shifts, unusual irritability, sudden mood swings, anxiety, depressions, change in sleep patterns. So, what are the emergency red flag signs for which we should be cautious? Seek immediate emergency attention if there is weakness or numbness, slurred speech, anisocoria means dilatation of one or both pupil, loss of consciousness, repeated vomiting, seizures. In infants and young children, very difficult to communicate with them. So we can mark the persistent crying, loss of interest in toys, unusual irritability, changes in nursing or eating habits. So what are the initial management? First is stabilizing the patient, then preventing secondary brain damage, then to identify life-threatening conditions like intracranial bleed. So initial first aid, pre-hospital, that keep the person still, have the person lie down with their head and shoulders slightly elevated, avoid moving their neck or spine to prevent potential spinal cord damage, control bleeding, apply firm pressure to the wound with sterile gauze. To be noted, do not apply direct pressure if you suspect a skull fracture. Then monitor vital signs, watch for changes in breathing, alertness. If they stop breathing, unresponsive, carotid not palpable, then we can go for a cardiopulmonary resuscitation. Do not remove helmets. If the person is wearing a helmet, leave it onto avoid unnecessary neck movement. The early clinical stabilization, the importance is of golden hour. So what is the golden hour? It is the 60-minute window directly after a traumatic brain injury. What is the importance? Its purpose is to prevent secondary brain injury caused by lack of oxygen, hypotension, or swelling, which can cause irreparable brain damage. So it aimed at reduce mortality, significantly improve long-term survival rates. So action is within this golden hour, we have to do immediate stabilization, stabilize the neck and spine, maintaining oxygen supply, and rapid transport to a trauma center. So principles of early stabilization. Just like every resuscitation, same thing, airway, breathing, and circulation. To maintain the airways, we have to secure the airway. If the patient is comatose, GCS is less than 8. To maintain the breathing with adequate oxygenation, should be saturation minimum more than 94%, avoid hypoxia. We should prevent hypertension, systolic blood pressure should be more than 90 to ensure adequate cerebral perfusion pressure. Adequate fluid resuscitation should be there. We should maintain euvolemia, use isotonic fluids, avoid hypotonic or glucose containing fluid to prevent cerebral edema. Next, cervical spine immobilization. Assume spinal injury in all significant head injury case. To stabilize, maintain the neck in a neutral position using a rigid cervical collar and minimize movement during patient transfer. Prevention of secondary brain injury. Avoid hypoxia, hypoxemia, hypotension, intracranial pressure control. I already told to maintain a cerebral perfusion pressure 60 to 70 mmHg. Positioning, elevate the head of bed to improve venous drainage and reduce intracranial pressure. Temperature control is almost important. Treatment fever and manage normothermia, because of hyperthermia there is increased cerebral metabolic oxygen demand. Glycemic control to maintain glucose control between 80 to 180 milligram per deciliter to prevent cerebral edema. So immediate assessment and monitoring, we have to monitor the GCS, Glasgow's Coma scale and score, and PPIL. So if the GCS is less than 8, already I told, we have to maintain the airway and intubation, all these things, and identify deterioration which may indicate the temporal herniation. Imaging a must perform an urgent CT scan to identify surgical treatable lesion. There may be intracranial bleed. So seizure prophylaxis, consider an early anti-epileptic prophylactic, usually phenytoin for the first 7 days. So proper transport, rapid transport to a center with neurosurgical facility, stabilize before transport, ensure the patient hemodynamic is stable and airway is secured. Coming to Glasgow Coma score, there is eye opening, verbal response, and motor 3 parameters. It starts from 1 to range from 1 to 15. If there is spontaneous eye opening, that is 4. To sound, it is 3. To pressure, it is 2. And no eye opening, no response, it is 1. Verbal response oriented, it is 5. Confused, 4. Inappropriate words, it becomes 3. Incomprehensible sound, it becomes 2. And no verbal response, it is 1. Again, motor response, obeys command is 6. Localizing, 5. Normal flexion, 4. Abdominal flexion, 3. Extension, 2. And no motor response, 1. So severity, severe is 3 to 8. Moderate is 9 to 12. And mild is 13 to 15. Now comes trivial head injury. What is trivial head injury? That is, if someone just bump his head on the wall like that by accidentally, low impact bump to the head, that does not involve loss of consciousness, amnesia, or neurological deficits. Symptoms are usually mild, minimal headache, transient nausea, resolved within days without complications. Home care and monitoring, rest, cold compression, analgesics, paracetamols, avoid aspirin for bleeding risk. Careful observation required for hour to days. What are the signs which need medical attention? Again, same as almost the early red flag sign that already we discussed. The loss of consciousness, recurrent vomiting, worsening headache, confusion, slurred speech, seizure, numbness extremities, physical signs of skull damage like CSF rhinorrhea, bleeding from ear and nose, and anisocoria, unequal pupil, more than 1 mm is significant. Then comes to anticoagulant modifications. Means, suppose a patient in anticoagulant for a metallic valve, heart valve, or anything, and a patient experience a sudden traumatic brain injury. So we have to maintain the balance between expanding intracranial hematoma and risk of life-threatening thromboembolic event. So immediate sedation is warranted if the head injury is confirmed or highly suspected to prevent hematoma expansion. But here hematoma expansion prevention is more important. Acute reversal is needed when the CT imaging shows active bleeding. How to do active reversal? As for the agent specific. So reversal agents are for warfarin, we are giving vitamin K or 4-factor P prothrombin complex concentrate. Dabigatran, there is adalimumab. For rivaroxaban or apixaban, andexanet alpha, and 4-factor prothrombin complex concentrate. For heparin, there is protamine sulfate. So at Then when to do anticoagulant resumption, when to restart anticoagulant. If there is high thromboembolic risk, just like mechanical valves, recent venous thromboembolism or atrial fibrillation, we should wait till 72 hours, 3 to 14 days, we can start. If lower stroke risk, non-valvular atrial fibrillation, minimal risk, then within 4 to 8 weeks, we should start. Minor head injury, normal CT scan, treatment continued or resumed very early once a delayed bleed is ruled out. Confluent bleeding, intracranial hematoma, prophylactic anticoagulation 3 to 7 days, therapeutic anticoagulation 1 to 4 weeks after injury, provided follow-up imaging shows hematoma is stable. Anticoagulant resumption, already I told, preference for direct oral anticoagulant, Apixaban and Rivaroxaban over warfarin because of lower risk of recurrent intracranial hematoma. Venous thromboembolism prophylaxis, IPD patient not on oral medications, then low molecular heparin started as early as 24 to 70 hours. If the no active bleeding, if a patient is stable, to prevent deep venous thrombosis. So observation protocol on anticoagulant with normal initial brain CT scan, then 24-hour observation needed, 48 hours observation needed in case of if the patient is elderly with more than 65 years with INR is more than 2.5. The second safety CT scan is needed before discharge. Follow-up imaging needed if a repeat CT scan within 6 to 24 hours if there is initial scans of bleeding or if the patient's neurological status changes. Thank you.
Thank you, Dr. Bhakti Prasad, for the detailed view about the acute management of head injury. We move on to the next panel discussion. Dr. Subramani will be taking on the panel discussion. Over to you. Dr. Balasubramani comes from Ganga Hospital, one of the best trauma centers known to us at Coimbatore. Over to you, Dr. Bala.
Thank you, Yash. Can I share the screen? Is it possible? Hello? Yes? Dhaval? Hello? Yeah. Is it possible to share the screen?
Yes.
Yeah, we cannot see your slides. Or
Sir, I think your desktop screen is visible, but you can make it full screen and then maybe you can try, sir.
so this is not my screen. This is previous speaker screen.
Okay.
Dr. Bhakti
So
Prasad, can
we
you
just need
please
to,
exit
Dr.
that?
Bhakti, can you just stop sharing and then Dr. Subramani will be able to do that, please.
How do you share it? Engage. Share screen. Can you see my screen? Can I see? No, still we can't see your screen. Meanwhile, you put on your screen. We will introduce the panelists. Yeah, please. Dr. Uma Hariharan. Dr. Uma Hariharan is from RML Hospital, Delhi. Dr. Abraham Koshi.
Good evening,
Dr.
all.
Abraham Koshi is from Tiruvalla, Kerala. And Dr. Gunadhar Padi from Mumbai. Over to you, Dr. Bala.
Hi, sir. Good evening.
Good evening, everyone.
Good evening, sir.
Good evening, madam. Coming up. Yes. So, Dr. Abraham, yeah, your video is off, I believe. It's not able to share still. Top video. Dhaval, just check. Do I have to be a co-host? Not necessarily, but
No.
it's yeah. Okay, perfect. Okay, so we have. Thank you very much, Yasha, for inviting us, and we have an excellent panel along with me. Shall I start? I thought I will take the entire journey from accident to recovery through a case presentation.
Yes, sir.
Yeah.
Yes, sir, please.
Okay, so this is a 48-year-old patient. Is met with an RTA, two-wheeler versus four-wheeler, and 2 hours ago, he was not wearing a helmet. The injury sustained injury to the head and chest, and he had a history of LOC at the scene and nasal bleed present, 1 episode of witnessed seizures. He took initial treatment local hospital and transferred for further care. Patient arrived 2 hours later. He was on oxygen mask and IV fluid started. So shall I ask Dr. Kumar, what is your initial management plan for such patients when they come here?
Yeah, first of all, thank you, sir, and thank you, SNCC, for the opportunity. Basically, this is a case of road traffic accident, which we normally encounter. And my initial priorities will be ABCDE. And as per the latest 11th edition ATLS guidelines, it is XABCDE, where X stands for control of exsanguinating hemorrhage. A is for airway control with cervical spine protection. B is for breathing with ventilation control. C is for circulation with hemorrhage control. D is for disability, that is our neurological assessment and control. And E is for environment control as well as exposure. So my priority will be to identify and treat the life-threatening issues immediately.
Excellent, madam. So now, as madam said, we have gone through the primary survey. Patient was restless with noisy breathing, and the saturation is about 90% on 6 liters oxygen mask. Respiratory rate is about 22 per minute. Heart rate about 110 and BP is 90/60. Is making sounds, eyes opening to pressure stimuli in the nail bed. There is an abnormal flexion when pressure applied on the nail bed on both upper limbs. There are multiple abrasions over the chest and abdomen. Madam, what next, madam? This is your patient now.
Yeah. So
what
as
can we do?
yes, sir. So this is the usual presentation in a case of polytrauma where almost all aspects or all systems of the body are affected, and each and every vital aspect has to be taken care of, especially the airway. So we will start with A, since the patient is restless and having a noisy breathing, and also he's making sounds, as you can see, like the sounds are the patient is having a low GCS. If you can understand that a patient with GCS less than or equal to 8 requires immediate airway management and a definitive airway. So the airway is threatened, and I would like to go in for a definitive airway with drug-assisted intubation. And I will definitely, take care of the pre-oxygenation and the prevention of hypoxia, as well as hypotension. Both are the harbingers of secondary brain injury. So I will have to give adequate pre-oxygenation, para-oxygenation, and take in a rapid sequence induction or a drug-assisted induction, wherein there will be avoidance of both hypoxia and hypotension with cervical spine control and manual inline immobilization. That is what is my first priority, because the airway is threatened. And next, as you can see, that the heart rate is slightly on the higher side and the blood pressure is also on the lower side. The patient is in shock. I have to investigate, and most commonly in a patient of trauma, the most important cause is hemorrhagic shock. So that has to be ruled out. And of course, large bore IV cannulas and giving warmed balanced crystalloids and sending blood for cross matching and doing an e-fast to see where is the hemorrhage. Blood on floor and 4 more is what is the dictum, the phrase which is used. And since the GCS is of course 7, around 7, it's a case of traumatic brain injury. I would like to intubate and secure the airway and give controlled ventilation. And of course, there are abrasions over the chest and the abdomen. This suggests that there could be injuries at other places, for example, a pneumothorax or hemopneumothorax, and inside the abdomen there could be intra-abdominal hemorrhage. So all these things have to be ruled out by a detailed examination and primary survey and doing the resuscitation then and there. So if there is a pneumothorax, I will have to do an ICD and then proceed further.
Thank you, madam. That's, as you rightly said, hypotension and hypoxia is the two main killers of a head injury patient. And also, madam pointed out, when there is a hypotension, it's very unlikely the hemorrhagic shock is the most likely from other areas rather than from the bleeding in the brain. So you need to look for, when there is a hypotension, look for other areas of bleeding. Okay, excellent, madam. So now the patient was intubated, and the vital signs as BPS marginally increased from 100 to 110, 90 to 110. Now SATs is about 96%, the patient is put on ventilator. Now, having intubated this, madam, how do you monitor this patient's neurological status, and what is the next plan for this person? Uma, madam?
So this question is for me?
Yes, madam.
All right. So basically, monitoring of the neurological status starts with monitoring of the vital parameters, and it is firstly clinical. The most important clinical parameter which we have to monitor is the Glasgow Coma Scale. The Glasgow Coma Scale is, of course, as I told you, if the GCS is less than or equal to 8, we need to intubate the patient and secure a definitive airway. But a single reading of GCS is not what is going to help us. We have to do a serial measurement of the noting down of the GCS, and that is what will tell us the trend towards deterioration or the trend towards progression of the traumatic brain injury. So that is what is important. Second is the pupils. The pupillary reactions are sometimes difficult to elicit in a traumatic situation, because sometimes the patient may also have concurrent ocular injuries. The patient may also have concurrent facial-maxillary injuries. But yes, they do serve as an important aspect in analyzing the deterioration in a patient. For example, if there is anisocoria, sudden anisocoria in such patients, it would suggest that there is a sudden deterioration, and we need to repeat the CT scan to understand whether there is a deterioration in the traumatic brain injury status. Then, of course, the motor response. If the patient goes into a decerebrate posturing, extensor response from the usual motor response, then again, it suggests deterioration. And of course, the brainstem and the corneal reflexes, the gag reflex, the cough reflex, and these are the clinical aspects which we are used in monitoring. And also monitoring, as I told you, monitoring of the vital parameters. Now that is important because we have to measure the CPP, that is the cerebral perfusion pressure, which is nothing but the mean arterial pressure minus.
We'll come to that in a minute, madam. We'll come to that pressures then, madam.
Okay, sir.
So what next for this, madam? Now we have achieved some stability, cardiovascular stability and respiratory stability. So what next we need to consider, madam?
Yes, so we have to do a CT scan.
Yes.
So the CT scan is what will tell us where is the injury and what we need to do.
Okay. So as we see the CT scan done, and it showed subdural hematoma with midline shift. And what is the next line of management, madam?
Sir, this is a case of severe traumatic brain injury. The patient is intubated. The CT scan is evident. We need to call in the neurosurgeon, and the patient needs to be taken to the OT for a proper craniotomy, a fronto-temporoparietal craniotomy, and evacuation of the hematoma needs to be done. And the patient needs to be followed up serially with CT scans and clinical monitoring to understand where is the CPP, where is the intracranial pressure, is it rising or is it the same, or is the patient improving GCS-wise?
Okay, madam. So as he suggested, the patient has been taken to theatre. Patient underwent fronto-temporoparietal craniotomy and evacuation of the clot has been done. Fairly uneventful, patient was shifted back to ICU for further management. Now, can I ask Dr. Koshi about how do you manage this patient? Now, the patient has come into the ICU. So how do we manage this patient initially and subsequently in the ICU, sir?
Good evening, sir. Thank you, SNCC, for the opportunity. As we have seen, this is a severe TBI patient post frontotemporal craniectomy, now has come for ICU management. So Our focus here again will be to prevent secondary brain injury, first of all. Make sure that the brain is adequately perfused and then try and address any systemic complications. So our focus would be to maintain adequate oxygenation, avoid hypoxia, avoid hyperoxia, make sure that you avoid hypotension at all costs, make sure you have stable optimal hemodynamics, and make sure that we have a grip on the ICP to prevent any secondary brain herniation. Of course, we have done the surgery, so that should take care of the ICP adequately, hopefully, and make sure that our PCO2 levels, we don't have it, are normal, we don't have any fevers, and make sure our glycemic control is adequate. And since this patient is immediate post-op, we may need to plan for adequate analgesic sedation for the next 24 to 48 hours to make sure that we avoid any ICP surges. That will be the initial plan. Then, meanwhile, we'll make sure that we have adequate control over the ventilation. We'll try and make sure that, as we said, make sure our PO2 and PCO2 levels are in the normal range, and make sure that we have a lung protective ventilation ongoing. Along with that, we will make sure that we have adequate settings in the ventilator. We'll make sure we have.
बुधवार को इसका इंटरव्यू है, बुधवार को नहीं, मंगलवार से सवेरे आ जाना कोई।
We'll avoid a high PEEP ventilation because that may impair venous return.
नहीं 39 में नहीं आना, ऑर्थोपेडिक वर्कशॉप में आ जाना।
And make sure that we have adequate
वर्जिश है तो वर्जिश भी बता दें कैसे करनी है, क्या
sedation to avoid any ventilator disability. For the regarding
अरे वर्जिश देंगे, कार्ड बनवा के आ जियो।
I hope I am audible. Regarding fluids and transfusion.
Go ahead, Dr. Kaushik, that's fine.
Fluids and transfusion, our main aim will be to maintain euvolemia. Because in this context, we have to think of, because we are planning to be most likely hypertonic saline or mannitol, we make sure that patient we assess the fluid status and then decide which one to give and make sure we maintain adequate CPP. Our hemoglobin, our transfusion targets, because it's a post-surgical patient, we'll target around more than 7 to 9. And we may need to plan for a higher threshold if there is any obvious cerebral ischemia. Platelets of post-surgical patient will need to target a higher platelet count more than 1 lakh. Meanwhile, we'll target a serum sodium above 145 to around 155. Regarding renal support, as we said, we must maintain euvolemia. So we'll clinically monitor urine output. You will obviously look at the biochemical values, electrolytes, creatinine. And in this context, we should avoid maintain CPP. So we should make sure that patient is adequately filled, but at the same time, we should avoid fluid overload also. In this context, we have to also consider the possibilities of SIADH and cerebral salt wasting also, because it's a post-TBI patient. Nutrition and glycemic control, you will generally plan an early enteral nutrition, usually within 24 to 48 hours. And the glycemic targets for ICU patients, we'll target 140 to 180. And meanwhile, we'll make sure that we do not precipitate any hypoglycemia, because it will damage the brain, as well as avoid hyperglycemia. Mobilization, once the patient is stable, we may plan for early mobilizations, but at this point of time, we may need to plan for a passive limb physiotherapy while maintaining adequate position changes and head elevation. Once ICP is stable and sedation is reduced, we can plan for a early mobilization. DVT prophylaxis, because there is high risk of DVT due to the immobility and post-trauma status. Initially, post-surgical status, we can plan for a pneumatic compression at this point of time. Maybe after 24 to 48 hours, after the CT, we can plan for a pharmacological prophylaxis, provided there is no active bleeding and the CT is stable. Post-trauma patient, again, we have to think for coagulopathy. We'll, of course, monitor the coagulation profile, target an INR less than 1.5, platelets more than 1 lakh, and fibrinogen more than 150. And we'll decide on products depending on the values and the clinical status. So the approach would be primarily to protect the brain in the post-op period. Meanwhile, we'll try and address other complications and avoid any systemic issues.
Thank you, Kaushik. That's a very extensive elaboration of ICU management. And as you rightly said, edema control will be the first priority, and stabilizing and giving organ support is subsequently. What sort of targets you make for ICP and blood pressure?
Sir, the guidelines suggest ICP. We need to lower the ICP below below 22 because there is pooled analysis that suggests that an ICP level persistently about 22 has a correlation with high mortality. So ICP levels less than 22 will target, and CPP target that is suggested per guideline is 60 to 70. Where we have an adequate hold on the ICP, we may need to think of managing the CPP in the 60 to 70 range, because this will directly address the cerebral perfusion and avoid ischemic secondary injury.
Thank
Yes.
you. Thank you, Doctor. Thank you. So, who needs an ICP monitoring, in your opinion, Dr. Koshi? What are the options we have for monitoring this person? If you have an ICP, I'm sure that is not uniformly available across all centers. If at all it's available, and what's option for us?
Sir, for indications for ICP monitoring, guidelines says that severe TBI patients, GCS less than or equal to 8, with who has abnormal findings like a contusion, edema, or compressed basal cistern, it is indicated. Even patients having a normal CT, if there are 2 or more high-risk features like age more than 40 or a systolic BP less than 90, or patient having abnormal posturing, the Brain Trauma Foundation guidelines suggest that we need to go ahead with the ICP monitoring. However, of course, we'll need to individualize. If we have if our clinical exam is not reliable due to sedation, polytrauma, or paralysis, then we may have to individualize according to the patient's clinical condition.
That's right. Okay. And what options we have?
Options, sir, generally 3 main options. One is the gold standard that we consider is your external ventricular drain. It allows measurement of ICP, allows CSF drainage, therapeutic as well as diagnostic, and it may be useful in patients having an hydrocephalus or an intraventricular hemorrhage. Other option is the intraparenchymal monitor that can use the fiber optic devices or strain gauges. Studies have suggested it may be easier and quicker to insert, but there may be a risk of infection. Plus, it may not allow CSF drainage, and there is a risk of drifting of the this thing. And less common options are your subdural or epidural monitor. However, they have a lower accuracy and is not usually used in our settings.
All right. Okay. So, how do you manage the raised TB? So, ICP is raised. So, how do we go about managing the raised ICP? Dr. Koshi?
Sir, here we have a tiered management of ICP monitoring, sir, ICP control, sir. So in this patient, we have to initially make sure that we have adequate control of the airway, breathing, circulation, and make sure that we have basic management protocols in place. Like we have to avoid any compression of the neck. Make sure that we have a adequate head elevation. Make sure we don't compress any venous outflow. We make sure that there is no hypothermia, and we make sure that patient is adequately adequate analgesic sedation is given. And because it's a post-trauma injury and risk of there is parenchymal involvement, we can consider anti-seizure drugs also. Meanwhile, we'll make sure that your normal PO2, PCO2 levels are maintained. If in case your ICP is not getting controlled, we may have to plan to escalate therapy. So tier 1 management, we may have to consider hypertonic saline versus mannitol is the common hyperosmolar therapy that we use. Both of them help in decreasing the cerebral volume. So that is usually used.
neurological team so if
the ICP is still persistently high, then we need to plan for
ICP intracranial pressure. So if the patient neurological patient body jauchi to kon kara habo say management.
You continue with Dr. Koshi.
Yes,
That's
sir.
fine.
Yes, sir. So, tier 1.
Hello.
Hello,
Hello.
sir.
Yes,
Yes.
Dr. Koshi. Continue. You can continue.
Yes, sir. So tier 1. So if the ICP is still not controlled with the initial measures, and if we have a EVD in situ, then we can plan for a CSF drainage and deepen the sedation. We can change from maybe a
Sure.
Fenda to propofol to make sure that we have better control of the ICP. Then if it's still not controlled, then decompressive craniectomy can be planned. Then if still not controlled, then we escalate transient hyperventilation. This PCO2 target of 30 to 35. Although this is only a transient measure, the PCO2 will usually normalize. So this is only a temporizing measure, and we can, if the sedation, despite adequate another sedation, if the CCP is still high, we may consider use of neuromuscular blockade also. And eventually, if still not controlled, we may have to plan for a barbiturate coma also.
Any medications you would be considered in TBI? Is an evidence to support that?
Sir, the common drugs that we use in this setting, of course, post trauma patient intubated post surgery, we'll definitely plan for analgesedation. Then the other drug, main cornerstone of our treatment will be hyperosmolar therapy, mannitol and hypertonic saline. Both of them help in decreasing the ICP by means of osmotic shift, and both are recommended in the Brain Trauma Foundation guidelines. Anticonvulsants evidence show that it may be helpful in preventing early post-traumatic seizures, less than 7 days. Common drugs that we use are phenytoin and levetiracetam. As per clinical profile, safety profile, generally levetiracetam is what we use. Then the other drug that we can use is, as we saw, neuromuscular blockade drugs. If we don't have a hold on the ICP, that is, we can use in refractory ICPs, and then barbiturates also. Then the other drug, we can use fluids and vasopressors to optimize CPP. That is also our concern. So initial choice, if needed, despite adequate filling, we may need to consider noradrenaline and try to avoid hypotension. Steroids at present are contraindicated in traumatic brain injury because the crash trial showed that it had a high mortality. So it is contraindicated. The other drug is tranexamic acid that it has some evidence. In trauma patients, polytrauma patients also, within 3 hours, it has been shown to have a decreased mortality. And in trauma, mild to moderate TBA also, studies have shown that in the crash 3 trial, it has shown that it is beneficial. And antipyretics and temperature control, because we'll avoid fever. That is also the drugs that we can use. And DVT stress ulcer prophylaxis in this patient is also indicated. We can use LMWH or plain heparin, depending on your creatinine values, and then proton pump inhibitors also.
How early you can start, Dr. Koshi, the DVT prophylaxis from evidence space? How early?
How early, sir? In this scenario, we'll wait for the initial 24 hours, sir. DVT prophylaxis by our pneumatic compression device, we can start straight away. But the pharmacological prophylaxis, at least initial for the 24 hours, we may have to wait until we get a repeat CT done. Then we can plan for a pharmacological prophylaxis.
It's always a touchy between neurosurgeon and intensive
yes,
care.
yes, sir.
Okay. So you already touched upon hypertonics and saline and mannitol. Is there anything better, one over the other, or there is no benefit, no significant difference between the two?
Both these are advised under the guidelines, sir. But we don't have a definite superiority over one drug over the other. Both of them have their benefits. For mannitol, it may be useful in it has a faster sort of action, and but the drawback is it may cause hypotension. It is not useful in patients having it is contraindicated in a patient having a AKI. So in a patient who is hypovolemic, and patient having a renal injury, you may need to avoid mannitol. Hypertonic saline, the advantage is it can cause volume expansion. So it may be useful in a hypovolemic patient. and it may be also safer in a patient compared to mannitol in a patient having renal injury, although there is a risk of hyperchloremia also. So there is no definite evidence showing one is superior over the other. You will have to take a call depending on the patient's condition, and then
Useful and selective patients, right? Yeah. So our patient underwent tracheostomy. He was gradually weaned off ventilation to humidified oxygen. In the meanwhile, he developed an EUTA, which was treated with antibiotics. And what's the role of tracheostomy in timing? Is that early or late makes a difference? Dr. Koshi?
Yes, sir. Tracheostomy, our primary aim here would be to facilitate weaning from the ventilator. So, tracheostomy per se doesn't cause a change in the outcome of the traumatic brain injury. So, there have been studies and debates regarding the timing of tracheostomy. Some suggest that early tracheostomy may be feasible, but with the attendant risk of going ahead with a tracheostomy in a patient who may recover after a certain duration of time. So late tracheostomy have the problem of possibility of worsening ventilator-associated anemia, prolonging the ICU stay. So there is no definite evidence to say that one has a mortality benefit over the other, early versus late. Here also, I think we need to take a call depending on the patient's clinical status. If the expectation we have expectation is that patient has a severe TBI and there is a likelihood of prolonged need for intubation, then we may need to plan for a early tracheostomy, and then we may have to decide on the timing of tracheostomy depending on the how is the patient's GCS, how is his airway protective reflexes, and then take a call.
Sure. So particularly in our settings, probably early tracheostomy will help in decreasing the ICU stay also, because the cost escalation also there.
Yes, sir.
So moving on, how do we prognosticate this patient's recovery? Any scores or models will help? Can I ask Dr. Rakpadi to come in and share his thoughts for this?
So thank you first of all, and thank you SNCC for giving me this opportunity. I think so till now the patient is being managed well in the ICU, but it is always a anxiety in the part of the relatives to always ask, so how is my patient doing, whether he's going to survive, whether he's going to recover, whether he's going to regain his full consciousness, or he can come back to the normal life again. This is always a question from the time the patient arrives in the ER. So basically the prognostication itself start in the ER. The patient arrives in the ER. It depends on how severe the trauma is, how severe bad is the injury is. Like in this patient, if you see the GCS is less than 8. Nowadays, a lot of newer literatures are coming up where they found that not only the GCS, but GCS along with the pupillary response in the time of arrival in the ER actually is determine the prognosis. Like the patient who is already having a fixed dilated pupil, even if the GCS is like something 3/15, is definitely having a worse prognosis compared to a patient who is having a asymmetrical pupil or one side pupil is reacting. So GCSP nowadays considered to be more superior indicator and scoring systems compared to the only plain GCS. And second thing is like the CT scan. So when you do a CT scan, particularly you see the finding like how bad is the CT. So there are different scoring system like Rotterdam scoring systems where they tell that the CT is like really bad. Like in this patient, if you see there are compression of the ventricles, there are severe edema, there are extradural hemorrhages, the patient is having a loss of gyri and sulci. So it's quite a pretty bad CT actually, if you see from the initial presentation. So this kind of patients usually take a long time to recover. So whenever we prognosticate such patient, actually you don't immediately jump to any conclusion that yes, your patient is not going to do well. Again, it depends on the age. Like there are a lot of newer scoring system which are now coming up, like something called as CBI-M. So CBI-M basically deals with like your clinical findings, the biomarkers, the imaging finding, the modifiers. So what are the clinical finding is already I discussed, like the presentation, initial presentation, mode of injury, the type of severity of injury, and the signs of raised ICP. All those are clinical predictors. And second thing is biomarkers. So nowadays, a lot of biomarkers are coming into play. Like in westernized countries, they are using a lot of newer biomarkers for the acute setting as well as for the chronic setting also. Particularly the biomarkers like your glial fibrillary acidic protein or neurofilament light light chain or something called as ubiquitin C hydrolysis. So all these things are basically now recent addition to the box actually, where they found that if in the acute stage, if the trend is continuously goes on increasing for a patient, actually those patients are going to have a long stay in the ICU and having a worse prognosis. So never jump or never rely on a single value, but rather than the trend is more important, particularly in the acute phase, the glial fibrillary acidic protein, and the chronic phase, something called as the neurofilament light chain. And there are a lot of literatures also coming up where they found that if you suspect like head injury where the patient is clinically stable, looks okay, GCS is 15/15, and you want to decide for a CT scan, sometimes in nowadays the westernized countries, they are practicing this biomarkers at the point of contact, that is called point of care biomarkers, where if the initial levels are very, very high, those patients usually sometimes they don't require a CT scan. But it is different for our Indian setup, because in Indian setup we always, even a slightest doubt in a traumatic brain injury, we don't want to take a risk, and we always go for a CT scan actually. So these are one score. And second thing, the scoring regarding the outcome, like once the patient is getting discharged from the ICU, particularly this patient where the tracheostomy is being done, he is being shifted to the ICU, to the rehabilitation care, the neuro ICU, the tracheostomy ward. So there are a lot of scoring system like the Glasgow outcome, the Glasgow outcome extended scale, something which is very helpful. Like particularly you divide the patient in different score from 0 to 8, and you see that which kind of functional impairment the patient is having, whether the patient is having a impairment in the upper part of the body, like particularly the brain, or the patient is having an impairment in the lower part of the body, particularly the spinal cord, the limbs. Then according to that, these scoring system are being devised. So the best scoring system is like in the GO scale, particularly when the patient is having some kind of consciousness which is preserved, and patient is able to do his routine activity, and patient is with support, he is likely to back to his own like room or own setup where he can subsequently improve. So clinical scoring systems are always a guide. They are not the final. So whenever we tell to the family, we have to like judge according to the percentage that this patient is bad, this patient CT is bad. So how many 60 to 70% or 70 to 80% cases, particularly this patient is likely to go a long recovery, and his outcome is particularly maybe sometimes like extended ICU and extended hospital length of stay. So this is one. And yeah.
Newer therapies, sir? Any newer therapies on the horizon?
Yeah, so there are a lot of there are a lot of newer drugs are also coming up in the pipeline. Actually, I have read about the drugs, but actually I'm not sure whether those are being used. Like sometimes they are sometimes used to have a good outcome in such neuro patients, particularly the newer anti-epileptics, something called as topiramate and its newer analogs. Then newer additions like the for the analogous sedation, particularly what you are using is like fentanyl, and now superior to that we can now coming up with ramifentanil and ramimezolam. Particularly it's a midazolam analog which is now being also published in clinical trials, and these are being found to have a less chance of depression, less chance of anxiety disorders, and less chance of delirium particularly, and winning the patient very fast from the your particularly the ICU journey. The technological advances, particularly I like to highlight regarding the AI models. So there are a lot of AI models, particularly the Apres 2 models, and there are a lot of digital twins where you can actually simulate the patient, particularly your patient, this patient. Particularly if you put the CT scan, the patient hemodynamics, the patient's total path of journey in the ICU, and they can actually tells you that how far the patient can progress in their journey in this head injury, particularly whether the patient will have some kind of deficit, or whether the patient is going to improve, is going to improve from the comatose state. So those are the different models, AI prediction models, and actually these are under the study and trials, and they are found to be very, very suitable, particularly something now being also adopted in the westernized country. So these are the AI model, particularly I can say the frameworks, which is actually now going to change the future in this particular neurocritical care. And this the same thing what I'm talking about, like the targeted therapy is the role of AI. So individualized therapy. So the dictum is it is a personalized, precise medicine. No single therapy fits to all. So you have to decide your patient depending on that. The map, like the map is not also fixed for all. Like which map the patient autoregulation is preserved. The AI also can tells you that. And that patient also, before developing hypotension, that is called hypotension prediction index, before 15 or 20 minutes, you can have monitor which will tells you that yes, this patient is likely to have hypotension and going to be in a shock. So those are the things which I like to highlight. But of course, these are not standardized. They are not adapted across all the centers. But yeah, there is a scope. I can
So
say.
a lot of role for AI in future, sir.
Yeah.
So anything about hyperbaric oxygen therapy? Something is coming up.
Yeah, so the particularly there are a lot of we have used certain hyperbaric oxygen therapy in certain patients, like particularly the head injury patient, and they are taking the multiple sessions. It is not like that the one session they will take and they will be better. So the therapies are such that they have to go to the hyperbaric chambers and they have to take multiple sessions, and then we have to have a follow-up. So the studies are very limited, particularly in India, but I can definitely say there is definitely a lot of scope in this area, because now a lot of hospitals are implementing the hyperbaric oxygen therapy in that particular centers. In Mumbai also, we have very large number of centers where this facility is available, and we are sending all the neuro patient to the rehabilitation care. So we need to follow up this patient. I think next 2 to 3 years, we need to have a lot of data, and then we can comment on that.
So it's a long journey for the patient to come back to the starting point where before accident he was in. And is there any role for physio and aggressive mobilization and that sort of home care using a multidisciplinary approach, getting the family ready for the subsequent?
Yeah. Definitely. So the role of physio, I think, is tremendous, because once the patient recover from the ICU after this patient, like his tracheostoma is now, he's won the winning trial, he's out of the ventilator. The only thing which will help is now the physiotherapy. And there are a lot of particular the newer physio techniques and methods, like particularly the something called as the AI enabled physio methods, which actually nowadays implemented to such patients. And the role of such physio are to prevent the muscle contracture is one, and second is to stabilize the muscles, and third is to strengthen the core muscles, and fourth is to also stimulate the something called as cognitive function. So nowadays it has been found that even if the patient looks to be in coma, actually 20% cases the cognitive function is still intact. So sometimes we are in a hurry to prognosticate the family, particularly the young patient, that this patient may not going to come out from the coma. But nowadays a lot of therapies, like particularly the something called as the high frequency MRI stimulations, which are being done, particularly in such patients where actually they are found to be having a lot of improving the cognitive functions. And the physios are particularly the neurophysiotherapy role is tremendous, particularly in this case. And he has to work along with the intensivists, the neurophysicians, the neurosurgeons, so that he needs to understand better that which phase and which part of the muscle group need to be activated. And particularly these patients have contractures, they have something called as the foot drops, they have something called as the muscle loss, atrophy. So all these things needs to be understood. So that is the reason. So repeated physiotherapy, mobilization, early mobilization, DVD prophylaxis, DVD prevention is also helps. Like if you mobilize the patient, it will help to prevent the deep vein thrombosis also. And always try to have a multidisciplinary approach with your neuropsychiatrist, the physiotherapist, the psychologist, the counselor. And the first thing is like families should be well prepared. They should given a definitive plan, and they should also prepare, like the patient should go home and how to care for the patient. Like nowadays hospitals are sending their own physiotherapists to the home, their doctors to visit the patients and to see their outcome actually at home also. So home care is now actually gaining a lot of popularity, particularly such patients, because these patients are likely to be at home for a long time, for years sometimes, and they may develop a lot of complications at home. So those things are sometimes telemedicines also I can focus. The telemedicine also play a bigger role in such patients, and they actually find out the problem parts and they update their primary physicians, and that actually helps a lot. Yeah.
Thank you, Dr. Pati. That was wonderful, summing up all the journey for the rehabilitation. As this head injury patients moving from accident, survival is only one aspect, and then moving on to prepare the family, prepare the rehabilitation, it is a lot of input and from other departments. It is truly a multidisciplinary approach. And can I ask all my panelists with some of it, two lines, starting with Dr. Uma, 2 lines in what of time?
Okay, so the home care and preparation of the family is something which is not only, scientific, but it also has an emotional connect.
True.
And it also has several financial and other social aspirations and obligations and aspects to it, that it is a truly multidimensional therapy, or a truly multidimensional aspect of treatment of traumatic brain injury, and it actually is the least addressed because we have to look into multiple dimensions. Not only, as Dr. Gunadhar sir said, that we should have a good neuropsychologist, a neuro rehabilitation specialist, a nutritionist, a physiotherapist, a person at home. The care of the caregiver is also very important. The care of the caregiver is actually quite not talked about or not given
What about correct?
importance. Yes. So that leads to a lot of misunderstandings, misconceptions, and ultimately leads to the reduction in the outcomes or reduction in the quality of life of the patient who has actually been, shifted home or being planned to be shifted home for home care and a slow recovery at home. So the home care aspect needs a complete overhaul, and a specialized neuro home care is what I would recommend. And the nursing care, the physiotherapy care, the nutritional care, and the care of the caregivers. There has to be separate workshop or separate courses or separate, I would say, training and awareness.
Yes, madam.
In
These are the
this,
right. Yes, madam. These are all the right areas we need to, I think,
yes,
not addressed and focused.
yes,
Thank you,
yes.
madam. Can I ask Dr. Koshi to add 2 lines to what madam already said?
Just two points, sir. One is most of these patients likely to be young, so it's a very hard challenge for the family that we have to take in. Sometimes they may be the only sole bloodwinner also.
Exactly.
But it's a very difficult situation. So then we have to make sure that family is adequately taken care of, and we need to give proper counseling. Second thing I would like to highlight, there is a gender aspect also. In comparison to a male patient, if a female patient comes, then the challenge is manifold higher. So especially young female. So that those two aspects I would just like to highlight.
Thank you, Dr. Koshi. And Dr. Pati, just
Yeah,
quick word.
so for me, I think this is one of the very important webinar by, I really thanks SNCC, because this is now the challenge of the time. So I just have two words like Dr. Uma said, like care of the caregiver is one of the important aspect, and second thing is never like declare or never leave a patient who is young and who is presented to the ICU in a bad shape. But I have seen, or there is a high chances that this patient sometimes may recover to the normal life. That is what my take home message. So do the best.
Thank you. I'll try to thank all my panelists. To conclude, our patient made a good recovery. He was sent home with a tracheostomy tube, and he was started following simple commands, but there was a little bit of weakness on the right side, where he started mobilized, and he started following simple commands. Thank you very much, and I'd like to thank Dr. Yash and SNCC for giving that opportunity as well. Over to Yash.
Yeah, thank you, Dr. Balasubramani. It was a very candid discussion, and the flow was perfect, the timing was perfect. Thanks to all three panelists, Dr. Abraham, Dr. Gunadhar, and Dr. Umar and Madam. There are two questions in the chat box. I'll put both the questions. The first question I will put to Dr. Bala. Dr. Bala, this question is from Dr. Shruti. Can ONSD or TCD be a replacement for ICP in TBI?
I think the important thing is it's ICP management. It's not universal. One is cost and as well as availability. And in that kind of scenario, I cannot have a like comparison, but definitely it gives an opportunity. TCD now we are starting using from emergency. Even our ICU started using because everybody can be ICP monitored. So the TCD has definitely a role, and ONSCD, it's a user preference, and it's a lot of inter-user and same user variability there, which is taken into consideration. If it is, they're all very good tools, but it has to be rightly used.
Thank you. Next question is from Dr. Tom. I will put it to Dr. Gunadhar. Can you elicit few points about DAI, diffuse axonal injury, two salient features? Dr. Tom has asked this question.
Yeah, so basically, diffuse axonal injury is a type of severe traumatic brain injury where basically there is a high grade of injury and there is a deeper injury to the white matters, and the CT scan most of the times looks normal. So that's why it's like it's a clinical challenge. Like even if with a normal CT scan, when the patient is deeply comatose and it's a deep white matter injury, those patients we called as a diffuse axonal injury. So subsequently, like in a MRI, when you do an MRI, higher functional scan and other things, then you come to know that yes, there is a high grade of injury to the axons. And these patients are going to stay long and they are not going to recover completely, or they may be in something called as permanent vegetative states. So there are like lot of grading systems I like available here, like depending on the scans, the MRI finding, and particularly these patients are a challenge to the intensivist and to the family also.
Dr. Zirpe, sir, your comments, then there is another question. We'll take that question after that, sir.
Yeah, yes, and all panelists and all speakers, excellent discussion. And that's what we are known for. I will just summarize. We have done the survey of the PUMA, I think Himanshu has done in 2023. And almost we have participation from the 105 ICUs. The major finding was the cause of the coma in India was more than 50% as a head injury. Traumatic brain injury is one of the major reason for the coma. Okay, so that's the current situation. More than 50% is traumatic brain injury, then stroke, and then rest of the illnesses comes into that. So now we all need to work on the prevention. Road safety, road safety, road safety. Prevention is better than treatment. And it's a dynamic process, 365 days. We need to promote it that. Second part is, I don't remember, but some of the panelists very rightly say that their journey in ICU, that's what we should see. It should be the as early as possible. We should do the treatment to avoid the secondary brain injury and give them the better chance of survival and the faster recovery. So that journey in a critical care area, neurological care area matters a lot as a neurointensivist and intensivist to us. Third part is the discharge and neuro rehab. We are very bad in India. We need to work a lot on this because there are no intermediate unit from discharge to home. Our discharge destination is a home, and all these long standing patients or those who spends more time in ICUs and the ward directly goes to the home environment, which is very unsafe for them because they require a lot of neuro rehab. So we need to work on that as a society as well as the intellectual class from the society. How to create that awareness regarding the neuro rehabilitation and neurorehabilitation centers. And that is what the journey of the entire traumatic brain injury. It is not only prevention, it is not only management in ICU, it is not only discharge from the hospital. What happens to those discharged individuals and over a period of the months and years, how they survive, how they get the treatment, and how they recover. I think that entire spectrum is a World Head Injury Awareness Day rather than the one part of that. But it was nicely covered. Thank you. Thank you to everyone.
Thank you, sir. There's one last question from Dr. Jagviti Solanki. I will put this question to Dr. Abraham. What will be the dose of prophylactic Lavipryl in TBI? 1 gram or 3 gram?
Sir, generally in an ICU, we load with 1 gram. Maximum dose, of course, can go up to 60 mg per kg, up to 4.5 gram. But generally, we load with 1 gram, then usually give 500 mg or 1 gram BD. Then, depending on the clinical need and tolerance, we'll adjust the dose.
Weight-based dosage?
Maximum dose is around 60.
Yeah. Yeah. Okay. Thank you, Dr. Abraham. Any other burning questions or comments? Otherwise, it's time to close. Okay. I'd like to thank everyone, starting from our President, Dr. Prashant Kumar sir, our chairpersons, Dr. Zirpe sir, and Dr. Ranveer Tyagi. The first talk by Dr. Shruti, a very enlightening talk. It talked about the preventing aspect of traumatic brain injury. The second talk was from Dr. Bhakti Prasad, which talked about pre-hospital care and the emergency care of traumatic brain injury. And the last was very interesting panel discussion by Dr. Bala Subramaniam sir. And he discussed with panelists Dr. Gunadhar, Dr. Abraham, and Dr. Uma madam about the journey of the patient. It was a very reflective session and it was a good understanding from the pre-hospital phase till the discharge of the patient I'd like to thank each and everyone. And I'd also like to invite you all to World Walmart Day, which is on 22nd March. We'll be sharing the link tonight. Thank you, everyone. Thank you. Good night. Thank you.
Thank you, sir. Good night.
Thank you, madam. Good night, everyone.
Thank you.